Hi, I'm Dr. Donald Jurovich. I'm a professor of geriatrics at the University of North Dakota. Today, I'd like to present transitions of care. This is a topic brought by the Dakota Geriatrics Program, which is a HRSA-funded geriatric workforce enhancement program. And as you may have seen in previous presentations by myself, I like to incorporate imagery, pictures, paintings that help illustrate a point in older adult healthcare. And in this instance, I've presented Frederic Remington's painting of a cowboy who, coming down a mountain on his horse, doesn't look too steady. And this is very similar to transitions of care, where we often are navigating a rocky and treacherous trail. So our objectives today are to look at why care transitions are frequently suboptimal. And we want to look at the vulnerability of older adults during these transitions and consider what the risk factors are for experiencing an unsafe transition, as well as how we might be able to improve transitional care. And so you see this painting by Winslow Homer of a sailor shipwrecked with sharks circling around. There was great concern about this painting originally because Winslow Homer did not include the distant ship that you can see in the left upper background there, just a shadow of a ship, because without that ship there was really a sense of no hope for this sailor ever being rescued. And so later, Winslow Homer modified his painting to include that ship so that there might be an expression of hope. And so too, it seems that our transitions of care oftentimes are wrought with difficulties and bad outcomes, but yet I think there's hope as we look towards quality improvement in evidence-based medicine that can help in these transitions of care for this medically complex population. So I'd like to present a case presentation here. We have a 70-year-old diabetic man being discharged after a hospital stay for a open draining wound and possible osteomyelitis. You can see his inflammatory markers are quite elevated. He has an activity of daily living deficits that includes assistance for bathing and transfer. He's required to have antibiotics for at least 6 weeks and wound care. He lives alone and does not have friends or family who live close by, and he reports that he wants to go home. So what is the next course of action? So we have 4 choices here. Do you order home health to honor his wishes, consult psychiatry, evaluate his decisional-making capacity, or contact a social work for nursing home transfer? So the correct answer would be assessing decisional-making capacity. And I think all providers, hospitalists, primary care providers should have the ability to assess decisional-making capacity and don't necessarily have to refer to psychiatry or psychology to help make that determination. So another question here is, which is the appropriate location for discharge? Acute rehab unit, a skilled nursing facility, home with home care, and continuation of the inpatient stay. So the correct answer is skilled nursing facility. And this individual meets all the criterion for Medicare for transfer to skilled nursing facility. He likely had 3 overnight stays at the hospital, and he had need for intravenous antibiotics as well as intensive wound care therapy. The topics covered today are going to be risks of poor care transitions. What are the incentives, barriers, and responsibilities for making a good care transition? Also to look at strategies and models that have been tested for improving that transition, and to look at the different venues with which older adults are transferred. We also want to hone in on medication regimens, as well as the communication plans, and just overall steps to improve care transitions. So as we see in this handoff of the baton, a lot of times transitions of care are well intended, but they always end up having some defaults and glitches in the process. So as we talk about handoffs and transfer, these can be considered either within the hospital setting. So for example, when I was in charge of a geriatric unit at a large university hospital, we would often have transfers from surgical service to our geriatric unit. But the transfers can also occur across different healthcare settings. And so this typically would be from the hospital to, for instance, home health care. It could be to a long-term acute care, an LTAC, or other settings, including hospice care. So this demonstrates the complexity that we're dealing with. So you can see in the lower left-hand corner here the big H, the hospital, and you have the patient and their caregivers all interacting at different points in time with, firstly, perhaps the emergency room here, maybe into the intensive care unit, hopefully not. More likely a med-surg unit, which might include, in some instances, a ACE unit, which is an acute care for elderly unit. This has demonstrated much better outcomes than the traditional med-surg unit as we know it. There's inpatient rehab, outpatient rehab, certainly different levels of primary care up in the left-hand corner here, and also issues related to transportation, medication, pharmacy, long-term care, whether it be skilled nursing care or intermediate care, and so forth. So you can see all of these possible combinations can really play an important role as an individual transitions from one setting to another, particularly that's precipitated by hospitalization and acute illness. And just to point out that sometimes there are opportunities for home care, segueing to a long-term care setting, such as respite care when the family or caregiver wants to go away for a period of time. They may have a week's worth of respite care in a long-term care setting as an example. So transitional care really is something that can be a problem. So in geriatrics, we often say that for each day in bed, there's 3 days of recovery that accumulate, unlike younger individuals where they may have an acute illness, but they get their so-called legs back in a very short period of time. So older adults, one of the facts there is that 15% of these individuals with no activity of daily living deficit prior to hospitalization will then, as a result of hospitalization, acquire a ADL deficit. Those patients with one or more ADL deficits prior to hospitalization, 45% of those will acquire a new and permanent ADL deficit. So basically, if you go into the hospital with one ADL problem, you're going to leave the hospital with an additional problem, and it's most likely to be permanent, part of that spiraling downward cascade of functional impairment. And importantly, one of the facts is that basically research has identified a 3 to possibly 6 month recovery window for returning to your prior or pre-hospitalization functional status, but after that, there usually is no additional recovery. So these transitions from the hospital are common and they're complicated. So We have 40% of older adults experiencing more than 2 transitions within 30 days of hospital discharge. That might be exemplified by transfer to nursing home, then to emergency room, and then back to the hospital, or nursing home back to the emergency room, and then back to the nursing home as an example. There's what some folks call post-hospital syndrome, which is an acquired and hopefully transient condition of vulnerability. This is associated with multiple health adversities, and it's all during this process of acute illness recovery, which has different trajectories for different folks. And we're seeing this actually currently in the pandemic, where some individuals, regardless of age, as it turns out, have post-COVID syndrome with long recovery periods for symptoms that are variable. Most of them are associated with chronic fatigue syndrome, for example. So it turns out that about 1 out of 5 Medicare beneficiaries will experience care transitions of some kind. So here you can just see the 50-50 split of those who do have some sort of transitions. Half of these individuals will go home. The other half may end up in skilled nursing facilities, which then again is split into another 50-50 distribution, where half of those individuals will go back home after short-term stays, and the other half end up becoming permanent residents in long-term care. So these suboptimal transitions cost a lot. There's, again, 20% of the population, just a little under that these days, will end up getting re-hospitalized after their first hospitalization, and that'll occur within the 30 days, first 30 days of their hospitalization discharge. Remarkably, this number goes up if you look at a 90-day span of time, so that fully 1/3 of all these older adults end up back in the hospital. So you can imagine, from Medicare's point of view, spending $15 billion a year probably is not such a good price tag for dealing with all these rehospitalizations. And in fact, while there's penalties that accrue to hospitals for going over the national average in rehospitalization rates within the first 30 days, it's likely that Medicare will change that into a 90-day period, and then putting the burden on healthcare systems to find ways to keep people out of the hospital over a longer period of time. One of the other suboptimal transitions relates to safety. And again, in the background here, we have a very stormy sea representing some of the issues that we see in transitions of care, such as medication errors that occur either on admission or in discharge. So it's always the points of transition that are the most vulnerable times that we need to think about. Also, how does the information get conveyed? There might be a delay in diagnosis. Why would that be? Well, it turns out that older adults more commonly present with atypical presentations of common issues, such as having abdominal pain while they may have pneumonia. And so you get steered down the wrong pathway, or the wrong rabbit hole, if you will, chasing something that may turn out to be not the correct diagnosis. Also, there's a lot of duplicative medical services. I can't tell you how many times I've seen older adults get multiple head CT scans for mental status changes, and it's just duplicative and uninformative. Of course, the hospital readmissions speak for themselves, and these all create a dissatisfaction both amongst providers and patients and their family members.